This is the case of a patient with ischemic cardiomyopathy, implanted with a dual-chamber ICD and hospitalized for lipothemia. This tracing illustrates the characteristics of an oversensing of the atrial activation. Atrial oversensing occurs in two main clinical situations: RV lead dislodgement to the atrioventricular junction, and when an integrated bipolar lead has been positioned near the tricuspid annulus, the RV distile coil crossing the valve. On the graph, we see a natural regular tachycardia and a typical aspect of railroad track suggesting oversensing of a cardiac physiological signal. And then here you see that the ventricular signals are exactly at the same rate than the atrial tachycardia. On the atrial channel, you can recognize the atrial tachycardia. On the ventricular channel, you can also recognize the QRS and some signals that correspond to the far-field atrial signals. The first one in the cardiac cycle are not sensed. The only one that is sensed is the one preceding the QRS. The QRS following is then sensed as a second very rapid ventricular EGM and is classified in the VF zone. After a ventricular sense event, the ventricular sensitivity threshold increases to 75% of the EGM peak, and then the sensitivity increases all along the cardiac cycle. This explains why these ones are not sensed and this one is sensed. This alternance between these two cycles, short, long, short, long, short, long, explain the typical aspect of railroad track. The AV conduction in this patient was abnormal. When there was no intrinsic conduction, the oversensing inhibited ventricular pacing, explaining the pauses and the lipothemia. Since there is no QRS here, the level of sensitivity remains very high, explaining the prolonged oversensing until the next intrinsic activation. The oversensing stops here because there is a spontaneous ventricular activation, and we understand why in patients requiring ventricular pacing and without any ventricular escape, atrial oversensing can be life-threatening with prolonged asystole. In this patient, two options can be proposed: lowering the level of ventricular sensitivity to prevent the oversensing of the atrial activity. This, however, incurs a risk of ventricular fibrillation under sensing. The second option will consist in repositioning the ventricular lead.